Welcome everyone to this evening's open public presentation of the physics department at Stockholm University. The speaker of today is Marta Lazzaroni, and she will talk about the art of radiotherapy. Let me first briefly introduce our speaker. Marta Lazzaroni is an associate professor at the Medical Radiation Physics Division. In 2009, she moved to Sweden to pursue her academic career at the Karolinska Institute as a Marie Curie PhD student. In 2013, she defended her PhD thesis. She teaches about radiation sources, radiation interaction with matter, radiotherapy, and radiation protection. Her research interests include adaptive radiotherapy based on functional imaging, light ion therapy with positron emitter beams, dose delivery verification in particle therapy, and mathematical modeling of tumor infiltration. We look very much forward to hearing your talk.
Thank you very much for the introduction, and thank you everyone for being here. And I would like also to thank the organizer for inviting me to give this open lecture about the art of radiation therapy. Now, what the word art here means is two things. It is clearly an analogy, but it is also an acronym. And what the acronym means in the context of radiation therapy, we are going to see together during the course of these 40 minutes together. Cancer, we know that is one of the deadliest disease worldwide, and it's the second deadliest disease in Europe after cardiovascular diseases. We know that cancer-associated deaths, they account for 10 million if we consider the whole world population. If we look indeed at some statistics, we see that the new cancer cases, as they have been reported for the year 2020 for both sexes and all ages, show us that the major contributors to cancer are breast cancer and lung cancer, sharing roughly 11% of the whole amount of new cancer cases, followed very closely by colorectal cancer, and then we have prostate, stomach cancer, liver cancer, and cancer of the cervix uteri. If we now focus on the male population, we see that the major contributor is lung cancer together with prostate cancer. And for the female population instead, we have that breast cancer dominate the whole contribution with roughly 25% of the new cancer cases reported. And if we now take a look at the mortality associated, so number of deaths that have been reported for cancer in 2020, we see that the total amount, as I mentioned, of cancer-associated death is 10 million, and the majority of them, 20% of this death, is coming from lung cancer. So lung cancer is the deadliest of all the disease types, followed by colorectal cancer, liver cancer, stomach cancer, and then we see breast cancer here and others. So if we compare now mortality with incidence, and if we look at this plot here, we see that worldwide the ratio between incidence and mortality goes as 1 to 2. But if we concentrate on Europe, we see that this proportion goes as 1 to 3. What about Sweden instead? So in Sweden, these are data reported from the cancer registry, from the Social Styrelsen website. And here we see how the incidence, so new cancer cases and mortality vary over time from the years, the 70s to data until 2020. And here we see in this plot that data have been divided between males and females, and these upper curves represent the incidence, and male population is indicated in green, in these curves in green, while females in purple curves. And then in the bottom side of the plot, we have the mortality. These upper curves here are divided in number of individuals, which are the thick lines here, full lines, and number of tumors that are indicated with these dashed lines, because one person can, of course, develop more than one cancer. So if we just take a quick look at this plot, we see that generally the trend is that the new cancer cases is increasing over time, while mortality is slightly decreasing in time. And why now is incidence increasing? Well, population, there are many different factors that one could think about. And clearly one is that population is aging over time, therefore it is more likely probability that they will develop cancer. And also there is a big impact on coming from the screening programs, which are making us more effective in detecting cancer than before, and also detecting cancer at an earlier stage, which means that the probability to cure this cancer and to have a successful treatment is going to be higher. And this could also be one of the factors why mortality is decreasing over time. We can detect cancer at an earlier stage, and therefore we have higher probability of a successful treatment. Moreover, we became better at curing cancer during time. And indeed, if we look at what are the available treatment options for cancer, for curing this malignancy, we can see that they can be schematically illustrated as divided in these 7 categories. And one of them is clearly radiation therapy. Now, radiation therapy was used since the very beginning of the discovery of the X-rays to treat cancer. Just a few months after the discovery of X-ray by Röntgen, which dated back on 8th of November 1895, the radiation was used for cancer treatment. In January 1896, Röntgen published his first paper, which had this title, On a New Kind of Ray. And now it was referring to what we call nowadays the X-rays. And we see that 1896, and it was just a few months after this, the publication, the release of this publication by Röntgen, 3 pioneers in radiation oncology understood the impact of this discovery for healthcare and for medical imaging in general, radiation oncology in general. And in 3 different places worldwide, the first radiation treatment started. And the first one of them was in Chicago, where they treated recurrent breast carcinoma. And in Lyon, they treated a stomach cancer. And also in Vienna, on the same time, almost in concomitance, they treated a skin tumor on a child, 4-year-old girl. So now these 3 places are actually disputing which of them was the first one in using ionizing radiation to cure this malignancy. What about Sweden? Sweden actually was very receptive in understanding the importance of this discovery, and that the use of ionizing radiation for cancer treatment. And indeed, only a few years, 3 years after the discovery of X-ray by Röntgen, the first cancer patient was also treated in Sweden, in Stockholm at the Stenbecks Institute. And what you see here is a photo of that time. You see the apparatus that was used. You see here a patient lying on this table. And also Sweden seems to have reported actually the first document of a successful cancer treatment. Indeed, here we see a patient that has this cancer in this part of the nose that before treatment, and then we see the patient 30 years after treatment. So Sweden was reporting this successful treatment very early, starts to treat patient. And indeed, in 1910, also the first oncological clinic in Sweden was born, and this is Radiohemmet. It was located at that time in Kungsholmen. in Stockholm. Some of you might actually recognize also the building from this picture. Nowadays, Radiohemmet is actually located at Karolinska Hospital in Solna, actually in the building next to us, which we are located at Karolinska Cancer Centrum. So this is how the Radiohemmet looks like now. Now, as soon as this radiation treatment started, people started to observe also the side effects connected with irradiation, with ionizing radiation. And the first deterministic effects, such as skin burns, were reported in concomitance with the irradiation. So it was the year 1896. And a few years after, also the first reports on stochastic effects, so X-ray induced cancer, start to appear, and it was 1902, where the first report was published. So nowadays it's clear, and it is very well known that radiation has an important role in curing cancer. But at the same time, we know that ionizing radiation can actually induce cancer. So what we say in our field is that radiation, it is actually a two-edged sword when it comes to cancer. And given the fact that radiation indeed can cure cancer, but can also induce cancer, if we think about the aim, the goal of a radiation therapy treatment, the goal would therefore be that radiation should kill, sterilize, eradicate tumor cells, but also at the same time spare as much as possible the healthy tissue that are in the surrounding of the tumor of the target. If we want to achieve this goal, then one could think about two main strategies. The first one is related to radiation biology, the radiation biology of the actual tumor and radiation biology of the normal tissue. Indeed, if we go from the treatment, which is delivered in only one fraction, one single section, and move towards a fractionated treatment, so a treatment which is divided in several fractions, in this way, the normal tissue have the time to repair during a treatment. So in that way, we can spare the normal tissues. Another way to spare the normal tissue and then concentrate radiation on the target and kill the tumor cell is, of course, target conformity. So, for example, one could think about irradiating a target by using beam coming from different angles, impinging on the target from different angles, so that radiation is concentrated at the point where these beams are cross-firing, which should be the center of your target, and then the rest of the normal tissue is spared as much as possible. And of course, the radiation beams should be conformed to the shape, the morphology of the target that we want to consider. So we are now going to concentrate and talk a little bit more about the treatment conformity. And there have been, during the years, many improvements, perhaps we can call it even revolution or quantum leap in the way of intending target conformality in radiation therapy. And if we look at this plot, we have here on the y-axis the anatomical conformality, so the target conformality, treatment conformality to the morphology of the tumor. And on the x-axis, we have the sophistication of the technique, so the complexity of the technique. Now, let's take this as an example. Imagine that this is our goal, our target, and we want to treat this goal with radiation. At the beginning of radiation therapy was only planned, treatment could only be planned on 2D images, 2D radiograph. And also the capability of shaping the beam according to the morphology of the target was really limited. Only beams of rectangular or square shape were available, and the beam shaping was really limited by only the use of beam blockers, as we call them, or wedges. So let's say that, taking again the example that I'm showing here, target conformality could only look something like this. In the years around the 70s, 1970, there was an important discovery in medical imaging and healthcare, which coincide with the high availability of the computer tomography. So the possibility of actually then making a radiograph in 3D from different angles became an option. So a 3D information on the target, on the tumor volume, became available. And also another important technique, or rather way of collimating the beam, start to become available. And this was the advent of the so-called multi-leaf collimator. And you see here an illustration of a multi-leaf collimator. So beam shaping and beam collimation became more and more sophisticated, and therefore the beam could better shape around the target geometry. So geometrical field shaping became an important option and became more and more adherent to the actual anatomy of the target. So again, from the same illustration, we could say that we were able to treat the target by reaching this level of anatomical conformity. Another important discovery and another important improvement in target conformality in radiation therapy came towards the end of the 90s, beginning of the year 2000, when intensity modulated radiation therapy then became available. In intensity modulated radiation therapy, not only geometrical field shaping is possible, but also it became possible to modulate the particle fluence, the beam intensity, beam element by beam element, as shown here in this illustration and in the one close by. This actually made possible to reach a much higher level of anatomical conformity. And here you see in this figure an illustration of a typical IMRT treatment where beams are impinging on the patient from several directions, and each of these beams is now modulated in intensity. Some years after, it was the advent of the so-called rotational techniques, such as rapid arc or VMAT, which stands for volumetric arc therapy. Basically, in a VMAT treatment, what we see is something similar to an IMRT treatment. So the beam is shaped according to the geometry of the target from a certain projection, and at the same time, the beam is modulated in intensity. But now, instead of having fixed beams, the beam, as you see in this video, is moving and being delivered as the gantry, the treatment head is of the LINAC, this linear accelerator, is rotating around the patient. Now, the improvement in anatomical conformality of a VMAT treatment with respect of IMRT, it's not always higher, it's not always very big, in the sense that there are cases in which actually IMRT is superior in conformality to the VMAT, but in general, there is a gain with rotational techniques. And then another important step ahead came with the advent of ion therapy. So ions intending protons or carbon ions, for example. Indeed, particles are, with respect to photons, are expected to have and to be able to achieve higher target conformality with respect to photons. And if we take protons, as in this illustration here, in this plot here, we can see quite easily the reason why this is possible. We know that particles, such as proton, as I said, they stop in the patient, they stop in the material. They are characterized by this particular depth dose profile. They have low energy, which is released the entrance channel of the beam, and then a large amount of the energy is released at a depth which roughly corresponds to the particle range. So before the particle comes to a stop, we have an increase in the energy that is deposited in the matter, and at the depth of the so-called Bragg peak. So what you see here now with this blue curve that I'm indicating, you see a pristine beam of protons, and this means that it's a monoenergetic beam of protons. And this is compared now in this figure with the X-ray curve, which is this black curve here. In particular, these are 15 megavolt X-rays. So now if we imagine that this is our target, our tumor, which extends in depth from 7 centimeter to 18 centimeter, of course, a pristine beam is not what you would use for radiation therapy, but you have to cover indeed the whole target extension by creating what we call a spread out Bragg peak, which means that we modulate and overlap different beams of different energy so that we can actually cover the whole target extension. And spread out Bragg peak for proton in this case would look something like this red curve that you see in the plot. And so if we now compare the depth dose profile of photons with the one of protons spread out Bragg peak, you still see that there is an advantage in using protons. There is lower energy at shallower depths with respect to the target, and there is, with protons, no energy that is released after the distal edge of the target. And this would, of course, then bring us to have increased target conformity and especially better sparing of the organ at risk, so organs that are particularly sensitive to radiation that might be in the surrounding of the target. But what is the current practice in radiation therapy nowadays? Nowadays, the current clinical practice is only directed towards a physical optimization of the distribution of dose according to the anatomy of the target and of the normal tissue. However, there is we know very well that, and evidence is accumulating, that there are other aspects that comes from the biology of the target of the tumor that should be taken into account. In particular, we know very well nowadays that there are actually sub-regions within the tumor that are more resistant to radiation, and this is due to the biological properties of the tumor. So to conform the treatment only to the anatomy of the target might not be a good choice. And indeed, the reason for treatment failure in several tumor types might be actually found in the fact that we are not accounting for an increased radiation resistance in some part of the tumor, but we are rather delivering the same amount of dose of radiation uniformly in the whole target, which might not be enough in order to counteract the resistance in certain tumor subregions. So currently, radiation therapy is not taking into account of this it is not taking into account this region of increased radiation resistance, and of course, it's not taking into account also which could be the spatial changes of this location during the treatment. However, functional imaging in radiotherapy could give us this precious information that could allow us to escalate the dose, boost the dose in these areas of increased radiation resistance. So the use of functional imaging in radiation therapy we could say that could open up for a new way of intending target conformality, going from a physical conformality towards a biological conformality. And this would also mean that we would need to abandon what it has been for many years, a kind of dogma in radiation therapy, which is the requirement of a uniform dose distribution within the tumor. The fact that the uniform dose distribution is given to the whole target comes from clinical experience and comes from tradition in radiation therapy, but it might be the time to abandon actually this dogma if we move from physical conformality to biological conformality. I mentioned functional imaging now, and you might wonder what is functional imaging, or you might wonder what are the techniques that allow us to give us this functional and biological information about the target. One of the techniques that can be used, or one of the imaging modality that can be used to have information about the biology of the tumor, is the so-called positron emission tomography, which is a very well-known technique in nuclear medicine and used for diagnostic, for example. What is the physical principle or the working principle of this imaging modality? Well, we can start by the physical principle and the procedure start by considering a positron emitting isotope, which could be, for example, fluorine 18. It is a beta plus emitter. And this positron emitting isotope can be linked, can be combined, labeled together with a molecule that is biologically active and in which we are interested about. For example, it could be glucose. Glucose sugar, it could give us information on a patient on the regions of increased metabolism. Then once this positron emitting isotope and this molecule are labeled together, we create what we call a radiotracer. The radiotracer is then injected in the patient, and this tracer would accumulate differently in a differential way in the regions where there is more or less need of glucose in the example that I made. So this means that we would have a higher accumulation of the tracer of the uptake in the brain, for example, or in the heart, but also in the tumor, because tumors are very well known to have an increased metabolism, rapid turnover, etc. So this would give us the possibility to visualize the areas where there is increased metabolism and where tumors are. And if we look at the physics of the positron emission tomography, is rather simple in the sense that we have a beta plus emitter, so a beta plus particle is a positron is ejected from the nucleus, and after a certain range, which is on the order of few millimeter, it will recombine with one of the electrons of the atom of the patient, and then from this annihilation process, 2 gamma rays of 511 kb of energy, which is the rest mass energy of an electron, are emitted, and most often they are emitted at 180 degrees, since this annihilation happens at rest in the majority of the times. And these 2 photons are emitted, therefore, in the same so-called line of response, but different directions. Now, if we place a detector surrounding the patient there, and we can detect in coincidence these 2 photons. And by the intersection of different lines of response, we are able to trace back the point where the positron was ejected, or rather the annihilation took place, which is a few millimeter distance, which depends on the range of the beta plus particle. So in this case, we can have a map of the tracer in the body of the patient and retrieve from that some biological information about the patient and the tumor that we want to analyze. Now, if we use different PET tracers, so different molecules are linked to this beta plus emitter isotope, we can have actually different information from a functional and biological viewpoint of the tumor and of its microenvironment. So, for example, here you see an head and neck case, and in the first figure, the tracer which is used is FDG, so fluorine linked to glucose, and show us the regions of increased metabolism. There are other tracers that could help us to see the areas of increased proliferation, as you see in this second figure, and then tracers such as F-MISO, for example, that give us the possibility of seeing region of hypoxia. And also the last tracer which that is shown here, it shows us region of angiogenesis. I mentioned hypoxia, and what is hypoxia is it's basically with this tracer we are able to see the oxygen content that there is in a tumor or patient in general. So hypoxia means lack of oxygen or oxygen at a level which is below the physiological level of the normal tissue. Now, it is very well known that when there is hypoxia, so lack of oxygen in the tumor, in those regions there is also increased radiation resistance. So it is very important actually to target hypoxia in a patient, and I will continue to talk about hypoxia a bit more in the next slides. So I mentioned that we can have different information from the biological viewpoint about the tumor, and we can indeed create what is called in the literature a biological target volume. So regions within the tumor that would be in need of a boost and of an escalation of dose. And now the concept of biological targeted volume actually is not new, it's more than 20 years old, but still the implementation of this concept has not reached the clinical practice. Since there are several things that still need, several aspects that still needs to be understood better, and several questions that still need an answer. I mentioned before tumor hypoxia, and I mentioned already to you that this is when there is hypoxia, this means that we have increased radiation resistance of the tumor. And indeed, hypoxia is considered to be one of the main determinants of treatment failure for several tumor types, for many solid tumors, such as head and neck cancer, lung cancer, and other types of cancer. And we know that when there are hypoxic regions, the dose in those areas might be in need of an increase, of an escalation up to 3 times with respect to the other regions in the tumor. So it is very important to target hypoxia. And here you see the hypoxic regions for the 3 different types of cancer. So we see brain cancer, lung cancer, and head and neck cancer. And in red here, you see the region with this reddish color, you see the region where there is lack of oxygen, so this hypoxic compartment for the 3 solid cancer that I'm showing here in this slide. So I mentioned to you that we would like to target this area that show increased radiation resistance. So coming back to the analogy with the heart, we want in a way to paint the dose within the tumor, in tumor subvolumes. We want to escalate the dose in tumor subvolume. Now, if we think of painting the dose within the tumor, there are 2 main questions that one needs to answer. The first one is how to paint the dose to which level should we escalate the dose. And the second problem, the second question that one might want to ask is, how should we perform this painting? So again, in the analogy with art, should we use a small brush or should we use a brush of large size? size? Should we, in other way, paint the dose voxel by voxel according to what we see on a PET image, or should we actually identify larger areas of hypoxia and give a uniform dose boost on those areas? So I'm trying now to attempt to give an answer, or at least discuss these two questions now. Starting with the first one, which is dose escalation. So to which level should the dose be increased if we want to counteract the radiation resistance of the tumor in the certain tumor subvolumes? Now, different strategies have been proposed in the literature, and I have here listed three main ones. The first one is only empirically based. So people have been proposing that the dose in the hypoxic compartment of the tumor should be escalated to a level of 10, 15, 20% more with respect to what would be normally administered to the tumor volume. This is only based on clinical experience, and it is an empirical guess. Then there is another strategy, which is a simple strategy that has been proposed in the literature, which is the following. So we should take the tracer uptake, the map of tracer in the patient, so the PET image, and then escalate the dose linearly according to the value of the uptake voxel by voxel. So a linear conversion between tracer uptake and dose. And then we have a third method, which is more complex and is based on radiobiological modeling and mathematical modeling. And this method consists in calculating what would be the dose that would be required to achieve a certain level of control of the tumor, certain level what we call tumor control probability. Now, as I said, the method that I'm describing in this third strategy is quite complex, and there are a few groups that have been proposing different strategy and different way to arrive to a mathematical model and a radiobiologically founded dose escalation strategy. One of the group is our group at MSF, and the work published by Toma Dasu and co-workers. So without going into the mathematical details and biological details of this model, I would like just to show you what are the main steps that this model takes into account. So we start with an hypoxia PET imaging. So an image of hypoxia, which could be, for example, F-meso PET image. So we have a distribution of the uptake of a radiotracer in the patient. And then by basically a calibration curve, we can transform this map of radiotracer uptake in the patient into oxygen partial pressure, so oxygen level expressed in millimeter of mercury. So we could go from radiotracer uptake to the so-called PO2 maps. So in that case, we would have done an image that represents the distribution of oxygen expressed in millimeter of mercury in the patient. From that map, one could, by using radiobiological models, calculate the so-called dose modifying factor, which goes from 1 to 3. So these are dose escalation levels that would be needed in order to counteract the radiation resistance of the tumor. Once these dose modifying factors are available, one could then retrieve or calculate which is the dose that is required for achieving a certain desired level of tumor control probability. So this method gives us a way to calculate the actual dose that should be administered to the patient in order to counteract the radiation resistance coming from the presence of hypoxia. And as you can see here, the method gives us a dose distribution which is changing, is heterogeneous, and is given voxel by voxel, heterogeneous voxel by voxel. This method that I have just in a few steps described to you has been further developed. We have tried to include also and combine also within the model the information of coming from other tracers. So we have tried in our group to use in a synergistic way, so in a combined way, the information which could come from different PET tracers. So not only use the PET tracers to identify different areas of radioresistance given by different biological processes, but rather use them in concomitance in a synergistic way. And here is how the method can schematically be described. So we start again with an F-MISO, which is an hypoxia tracer PET image. We convert the uptake to oxygen partial pressure maps, so oxygen level expressed in millimeter of mercury. And then we take an image of the metabolism, so an FDG PET image, and convert the metabolic information into density of tumor cells, rather tumor clonogenic density, so density of tumor clonogenic cells. And once we have a map of the tumor cells or tumor clonogens, we can combine this information with the map of oxygen in the patient, and again use them to apply some radiobiological model and use them to calculate this heterogeneous dose distribution at voxel level that should counteract radiation resistance. So now that we have some method, one of the three that we described, and in particular will refer to the third method that is based on radiological modeling from now on, we want to know what should we do with this heterogeneous dose distribution. Should we use it as it is, so paint the dose voxel by voxel, or should we use some other strategy? What brush size should we use? So again, we can come back to this analogy with art and take a look at this painting, which is a painting by Seurat, which maybe you know it was one of the main exponents of the so-called pointillist, where you see that the painting is done with very small strokes. Or should we use instead another strategy for those paintings? Should we paint as done in the self-portrait by Van Gogh using larger strokes, a larger brush? And indeed, in the literature, we find that different groups have proposed different strategies, which goes under the name of dose painting by number, which correspond on the use of a small brush for painting the dose. So painting the dose voxel by voxel, according to what it has been previously calculated by, for example, radiobiological modeling. Or we could actually start from this heterogeneous dose distribution in the patient and then use it to calculate some uniform dose escalation levels in the within the tumor. So, for example, one could set a threshold either in the uptake of the tracer or in the level of oxygen, and commonly a threshold for level of oxygen to identify the hypoxic compartment is 10 millimeter of mercury. And then once this contour, which corresponds to the hypoxic compartment, is identified, to escalate the dose on that region in a uniform fashion. And this strategy goes under the name of dose painting by contours. So dose painting by contour, we identify the hypoxic target volume by setting a threshold in millimeter of mercury, for example, so in the PO2 level, and then we boost the dose uniformly in this area. Another strategy that we have been working on, it's something in between. So dose painting by number correspond to use a small brush size. Dose painting by contour would correspond in this analogy to paint with a large brush. there could be different flavors on those clustering methods. And one of those strategy that we have proposed goes under the name of dose painting by boxes, and basically consists in dividing the target in cubes of, for example, 1 centimeter size, and then assign a certain dose escalation level to that volume. So paint with a medium-sized brush, so to say. In particular, what we were proposing in this approach is to paint with the maximum dose within this cubic volume, maximum dose to the painted this within this dose volume with the dose value that correspond to the maximum dose that we can retrieve from this dose distribution at voxel level. So here you see how in this dose painting by boxic approach, the dose distribution could look like. Sorry. So what I mentioned so far are different dose painting strategies, different dose escalation methods. But of course, we know very well that an image is just a snapshot of a moment. And indeed, things are not static and things change during treatment. And there could be several sources of changes and variation during treatment. There are anatomical variations, for example, linked to the tumor shrinkage, so changes in the actual conformity and morphology of the target during treatment, such as the one shown here. Here we see a head and neck case, and this is the tumor volume as delineated on a CT image. And then you see the same patient, but 3 weeks during treatment. And think that a treatment course of radiotherapy could last up to 7 weeks, for example. So after some time, we could have that the tumor is shrinking, the anatomy is changing, and therefore the plan that was made, the pre-treatment for this patient, could of course not take into account of the variation of the tumor during treatment. So it would not be clearly a good plan for this patient at week 3, where since we can see that there is a notable change in the anatomy of the tumor. There are several other sources of anatomy changes that could, now this one is shown in the order of weeks, but there are changes in the anatomy that could be on the order of minutes or days. Another source of variation in the anatomy is, for example, filling of some organs, like changes in the bladder filling during the treatment and so on. There are also not only anatomical changes, but there are also daily setup error when the patient is positioned in a radiation therapy couch. So there are setup errors which should be corrected for, and also there are beam placement errors in general. There are also, however, biological changes that happen during the treatment. And here you see some example of these biological changes that we can retrieve by looking at, again, functional imaging by the use of PET. In this case, I'm showing you 2 patients. So this is the first patient and the second one in the second row. And what I'm showing are PO2 maps, so partial pressure of oxygen distribution expressed in millimeter of mercury, as you can see in the scale here on this side. And we have now contoured the hypoxic compartment in this patient by setting a threshold on the PO2 at 10 millimeter of mercury, as I mentioned before. And here we see the hypoxic target volume pre-treatment at week 2 and week 5. So what you can observe is that the hypoxic compartment is changing during treatment. So from these 2 images, there is a change, but perhaps not that big. But in the week 5, we see that the hypoxic volume has completely disappeared. So the tumor had the chance to reoxygenate during treatment. And Also, we see changes in morphology and location of the hypoxic compartment in the second patient. We see the pre-treatment image, the image at week 2, and then very notable change in the hypoxic compartment at week 5 during treatment. We see that the hypoxic compartment that you see contour here has changed in morphology, has changed in location quite substantially. And of course, all these variations, both anatomical and biological, are patient-specific. And clearly, a treatment plan that is made on pre-treatment images cannot take into account for this variation. So it is clear that it is needed to adapt the treatment during radiation therapy. And now it comes the acronym that I mentioned at the beginning of in the title of the presentation. Adaptive radiation therapy is imperative in some cases. And indeed, in clinical application of adaptive radiotherapy, so far have been limited only on replanning the dose distribution and making a new plan based on changing on the target morphology and target position. So there have been corrections that have been made and are currently made in the clinic, but these corrections so far are only accounting for the anatomical changes. While what I think will be the future of radiation therapy it would be towards a shift from art to bioart. So a change, adaptation of the treatment based on functional changes. So far, the potential of this functional imaging for radiation therapy has not been fully exploited. Still, there are aspects to understand and limitations to overcome. But I think the future of radiation therapy will go in this direction, since we cannot avoid to take into account the change of radiation sensitivity during treatment. And here I'm just showing you a way to conceive this bioart approach, which could be made of, consist of a twofold approach. So one could think about using functional imaging of different kind. For example, in the method I've showed before, we could think about using the metabolic and information about hypoxia in a synergistic way in order to have pre-treatment tailor-made and a tailor-made treatment plan, which is specific for that specific patient, which takes into account the biological properties of the tumor and the increased region of radiation resistance. And we can, in a way, construct and plan for the best optimal plan at the beginning of the treatment based on functional images. And then administer this plan for some fraction and have at some point early during the treatment a checkpoint. And that this checkpoint have again images of the biology of the tumors, so functional imaging, PET images that are repeated. And for using this image, we can actually assess which is the response of the tumor to radiation. And if the patient is found to be a non-responder to treatment, then boost the treatment in those areas of increased radiation resistance. And maybe repeat this process a few times during the treatment so as to target those areas that shows more radiation resistance. So this approach, the bioart approach, clearly would mean that we have to have also a change of paradigm in the infrastructure of radiotherapy, going from a linear process, which consists on imaging of the patient, delineation of the target, making of a treatment plan, and then delivery of the treatment plan for all the treatment fractions of the radiotherapy regime, to another type of way of conceiving the radiation therapy process, which would consist on a sort of feedback loop. So at some point in the treatment, early during the treatment, one would need to stop assess the response of the tumor to treatment, and then localize those regions that show increased radiation resistance, and then, if needed, plan again, adapt the treatment based on functional and biological information. Now we are nowadays in the era of so-called precision medicine and precision radiation oncology. And I think that radiation therapy, and I'm not the only one sharing this opinion, of course, needs to encompass more than the ability of delivering a precise and accurate treatment from a technical viewpoint that conforms to the morphology of the target. Future of that radiotherapy may be lying on not only target conformality, but also in tailoring the treatment and adapting the treatment from a biological and functional viewpoint. We have functional imaging has great potential and as an important prognostic. It has inside an important prognostic information on the tumor, both prior radiotherapy than during radiotherapy. And however, a long way still needs to be gone through, because to translate this functional imaging information into clinical practice and to adapt the treatment according to the clinical and to the functional information clearly is still a challenge. There are still limitations that one needs to overcome, and still there are several challenging aspects that one needs to take into account. However, this does not prevent clearly us from going forward and going on that direction. And on this line, I close this talk by leaving with this word by South American writer called Galeano. You might have heard about him. And I thank you for the attention. Thank you for being here. I thank again the organizer, and I want to thank my close collaborators in the of the project, which are Juliana Tomadazu and Anna Ureba, and also our collaborator at national and international level, and my colleagues at MSF. So I thank you for your attention.
Thank you very much for this very nice talk. Wondering if there's any questions from the audience. Please raise your hand. So, I can begin at least. So I had several questions, but let me take the most speculative one where I don't know what the answer would be about the future. So you were painting this very nice picture of going from art to bioart and being able to use more sensitive brushes, essentially. But is there anything that could give a leap corresponding to these different steps when you went from 2D to 3D and to ion therapy at the end? Is there anything beyond ion therapy?
That's a very good question. Well, I think we would need actually to change plot, because on that plot we have only on the y-axis the anatomical conformality to the target. Now we are completely changing topic and changing way of thinking radiotherapy. So putting aside somehow the physical conformality, we want to focus on biological conformality. So we want to open another dimension, so to say, on the way of intending radiation therapy. So it will be something else, another plot.
Right, so I guess that what you were talking about today would essentially improve whichever level you were on the plot that I mentioned.
Yes, exactly, yes.
Right. Anyone that came up with a question? Otherwise, I could just have a very brief one. I saw that at the very beginning, when you plotted the number of cancer cases in Sweden per 100,000 people, there was a drop lately.
Yes.
Is it just because of underdiagnostics during the pandemic, or?
No, actually, it is also reported on the Social Styrelsen website that there is indeed a drop in the incidence for some cancer cases, which of course impact the whole calculation, the whole amount of the new cancer cases detected, in concomitance with the years 2019, 2020, and therefore with the COVID pandemic. So there has been reported a lower number of basically people that were looking for the healthcare and for going to the screening program, especially for prostate cancer and breast cancer. And this has caused this drop in the curve.
So you think it's not the real drop in cancer cases, but a drop in...
No, these are kind of so to say, an artifact due to the pandemic,
okay.
not a real drop in the cancer cases. Yes.
That's unlucky.
Yeah.
All right. I see no questions yet. So thanks again for very, very nice talk.
Thank you for inviting me.